Second on our agenda is a brief introduction about the guest speaker, and it follows as listed. We are glad to have you on this contact meeting where we need to interact on a very important issue that has to do with our health. It is a global topical issue that we all need to be aware of. And as a corporate outfit and in the healthcare industry, we want to give back to the society and our customers most especially. Once again, my name is Olayinka Odumosu. I'm the Marketing and Relationship Manager for the Specialist Laboratories Limited. Admin, next slide, please. It was conceived with the idea of providing efficient and qualitative laboratory services. We were incorporated in March 2002, and we commenced operation that same year. This means we've been in existence for over 18 years. The question that might be bothering your mind as I speak is, who are we? Like I said earlier, we are the Specialist Laboratory Limited, and our vision is to be the clear leader in clinical and laboratory services. Our mission is providing standard clinical laboratory services for the purpose of improving the quality of medical care. Our core values are professional excellence, responsiveness and inclusiveness, integrity, dedication, equity, and fairness. I'm going to talk briefly about some of the services that we offer, and I'll start with the histopathology. The histopathology of all surgical specimens to make a diagnosis. Take, for example, the breast lump. We also offer cytopathology services, which are fine needle aspiration cytology, the breast lump, and other surface lumps. Routine gynecological cytopathology in the likes of pap smear to screen for cervical cancer, cytology of body fluids, and aspirate as well. We're actively involved in the service of immunohistochemistry to further type cancer for treatment decisions. Next slide, please, Admin. Our other services are molecular diagnostics, HPV DNA testing to screen for cervical cancer, genetic testing of cancer for immunotherapy and personalized treatment of cancer, e.g., KRAS and BRAF, MSI testing in colon cancer, EGFR in lung cancer, etc. Our other services include autopsy services as well, training of pathologists, TSL workshops organizers in collaboration with colleagues in the diaspora. The lab also organizes workshops for medical practitioners and are major with the main aim of improving quality as well as awareness of available services in the laboratory. Next slide, please, Admin. This webinar is organized to create awareness on breast cancer. October being Breast Cancer Awareness Month, would like to educate the general public about the topic, which is, got a lump, what next? Once again, thank you for joining us. But I'd like to briefly introduce the guest speaker because our time is fast spent. She's no other person than Dr. Mrs. Adewumi Alabi. She's a clinical and radiation oncologist at the Lagos University Teaching Hospital and a lecturer at the University of Lagos, Nigeria. She's a fellow of the West African College of Surgeons and the National Postgraduate Medical College of Nigeria. She's also an IAEA, International Atomic Energy Agency fellow from Stellenbosch University, Tygerberg Hospital, Cape Town, South Africa. She's a member of African Organization in Research and Training in Cancer, that's AORTIC, popularly known as AORTIC. American Cancer Society of Clinical Oncology, popularly known as ASCO. Prostate Cancer Transatlantic Consortium, CAPTI. Association of Clinical and Radiation Oncologists in Nigeria. She has been so actively involved in the management of cancer and cancer advocacy. She has a passion for clinical research to improve quality of care in cancer patients. She's an investigator in an ongoing clinical trial called IRETA, assessing response of breast cancer patients in treatment in collaboration with Center for Global Health, University of Chicago. She also has special interest in the burden of prostate cancer among Black men. Please kindly join me in welcoming Dr. Alabi Adewumi.
Good afternoon, everyone.
Good afternoon, ma'am.
Let me share my slide so that are you able to see my slides?
Yes, ma'am, we can.
Okay. Good afternoon again, everyone. I'm happy to be here to share some knowledge on breast cancer with every one of us, and to use this opportunity to address some pertinent issues that we've all been asking, and we keep asking our doctors, and sometimes we're not so clear about. So I'm glad that the Specialist Laboratories is organizing this, and I hope that at the end of today's session, we'll have something to take home that would have learned, and something that will be informative and would add value to us. So the focus of today's discussion is who's got a breast lump, and is there a breast lump? Yes. What next after that? Just a brief introduction of what breast cancer is. Many of us are aware that, that breast cancer is an abnormal growth in the breast, and this is something which many people have not really been able to define what it is. Some call it a swelling, some call it a tumor. So we have all kinds of names for breast cancer. And because of that, there's so many misconceptions, myths and misconceptions about what a breast lump actually is, and when should you worry as an individual? When do you really need to see a physician? What should you do? So I also like to use this opportunity to also tell us that not every breast cancer is malignant, and not every breast cancer is a cancer. That's what I mean. Not every breast lump is a cancer. Sorry about that. And so some breast lumps may just be a swelling, which is a regular or normal swelling. So, but some can be cancerous. So you can actually have two types of swelling in the breast. We can have what we call a benign swelling or a malignant one. The malignant ones are the ones we call cancerous, and what it simply means is that the lump or the swelling has the tendency to spread to other parts of the body. So it can actually leave that location where it is in the breast and go to other parts, including the lungs, even the nodes, the lymph nodes in the armpit or in the supraclav, to the liver, to the bones, or the brain. Globally, breast cancer is the second most common cancer after lung cancer. So we don't have so much of lung cancer in our environment because we don't have so much of smoking habits. And in Nigeria, so we'll see that breast cancer is the commonest cancer in Nigeria. And it's also been accounted to be the cause of death as the number 5 cause of death globally, after several other cancers. So this cancer death statistics now. So breast cancer is the 5th commonest cause of death. Every woman is at risk of having breast cancer. Every woman that has a breast. So I believe every woman has a breast, and so every woman has a risk of having breast cancer. The female-male ratio, so men can also have cancer. So that's the figure there is supposed to be 1,000, ratio 1,000 to 1. So females have a higher risk. Males also have a risk. So males can also have breast cancer. So males who express a higher percentage of female hormones are at risk of having breast cancer. Many questions come to mind when it comes to cancers generally, including breast cancer. And the question you usually want to ask your doctor is, why do I as a patient have breast cancer? What is the cause? And for us, medically, we usually say that we don't know the cause of cancers, or we don't know the cause of the breast cancer, but we know that there are some factors that makes an individual to be prone or at risk of having breast cancer, and that is what we call risk factors. So researches have been done, and some factors have been identified for different individuals to say that, oh, this particular individual has breast cancer, why? And so these are called risk factors. We have the ones that are non-modifiable and the ones that are modifiable. For the non-modifiable ones, what it simply means is that you have no control over it. It's not your fault. It's not something you can actually stop. Whether you want it or not, you can't really stop it. And one of those is age. And so we say that age is an important risk factor. Increasing age is an important risk factor in breast cancer. When one is getting older, the risk of having breast cancer increases. And this is particularly seen with those of us who are of the Black race. The African Americans are at risk of having a risk of having breast cancer with advancing age, also at risk of having diagnosis of breast cancer at a late stage. So this group of people, the African Americans or the Blacks, are usually diagnosed at the late stage. And so that also means that the mortality in the Blacks or the African Americans is higher. So advanced age is a risk factor for breast cancer. That doesn't mean that you don't have it in the younger age group. And if at all anything, when we have it in the younger age group, the mortality from morbidity from it is also not very good. It's very bad. So, and gender, I've talked about gender. I said females are more at risk of having breast cancer. Then personal cancer history. An individual who has a cancer history of previous cancer before or in another location in the body is also at risk of having breast cancer. Family cancer history. So we talk about family history of, oh, the mother had breast cancer, the sister has breast cancer, or the aunt had breast cancer. So these are histories that that are significant and can make that individual to be at risk. And so that also leads us to genetics as well. So for genetics, when we talk about genetics, for genetic history, the individual may also be at risk of having ovarian cancer, or there's ovarian cancer in one of the siblings or the mother or the family. So ovarian cancer is also one of the risk factors for breast cancer. And usually we even say for individuals less than 50, when there's family history of ovarian cancer in women less than 50 years, there's every tendency that someone in the family too can have ovarian cancer. So we've talked about first degree relative, that's the sister or the aunt or the mother who had cancer. So the person can also be prone to having cancer, or two or more relatives who have a history of breast cancer or ovarian cancer. Then still talking about family cancer history, personal histories are also important in terms of individuals who have mutation, who have BRCA1 or BRCA2 mutation. So for this individual, there's a chance or high risk of 55 to 65% lifetime risk of having breast cancer. Then individuals who have histories of atypical hyperplasia or ductal carcinoma in situ or lobular carcinoma in situ. So pre-malignant lesions. So pre-malignant lesions means that the person has something in the breast that looks like or is about to become cancer. So that is pre-malignant lesion. That's what when we look at the atypical hyperplasia, high grade, and individuals who already have low in situ carcinomas. So in situ carcinomas are already malignant, they are just not invasive yet. So these are, remember what I've said, these are non-modifiable risk factors, factors that you actually have no control over. They are just in you and there's nothing you can do about it. Then early menstruation and late menopause. So we talk about the prolonged estrogen window for the woman. So individuals who started menstruating early in life and have and got into menopause late in life. So for these individuals, the risk factor is higher. And then individuals with breast density. So for breast density too, this is also a non-modifiable risk factor. So for the modifiable ones, these are ones that we can have control over actually. Our body weight, individuals who don't do physical activity as they should, alcohol abuse, smoking, exposure to hormones like pills, for one reason or the other, women who have had to have IVF done a couple of times or hormone replacement therapies, pregnancy and breastfeeding. Pregnancy is supposed to be protective in the sense that a woman who has had many children has broken the estrogen window. So it's supposed to be protective. So pregnancy this time around is in terms of nulliparity. Women who have not had children are at risk of having, who have not had children or who have fewer number of children at risk of having breast cancer. And then breastfeeding is also said to be protective. Breastfeeding meaning that individuals who breastfeed for an average of 1 year and above protect themselves because their estrogen level drops at that time. And so it's a protective form for them. So individuals who don't breastfeed well, it will be the other way for them. So they are at risk of having breast cancer. Radiation exposure too is a risk factor. So there are some environmental factors that can be looked at. Then we go to signs and symptoms. What do we look out for when we talk about breast cancer? So usually, in the greater number of times, there's actually a lump, even though it's not every time there's a lump. So there's usually a lump. Some women don't have any lump, or they don't feel any lump, and they may have cancer. Pain in the breast or axilla is not a common sign or symptom, in the sense that most often times there's no pain. Before pain comes to be, most likely the cancer would have advanced. So, but this is not to say that when you have pain in your breast, you shouldn't complain to the doctor. But most women will not come to the hospital because they will see a lump and they will say, oh, well, I didn't have any pain, there was no pain. And so because of that, they don't come to the hospital. And so by the time they come in a late stage when it has grown so big and most likely would have gone to another part of the body, which we don't want. Nipple discharge. Many women may have complaints of, oh, nipple discharge, water-like, milky-like, bloody-like. So sometimes the water and the milky ones are not so worrisome, like when you have a bloody nipple discharge. So the bloody nipple discharge, or brownish in color, is not something you keep quiet about. You must see your doctor to actually give you a proper examination and tell you why you are having that. Or if it is even milky or water, you should also see your doctor and let them tell you that it is fine. So nipple discharge is a sign and symptom. Nipple retraction, eversion, rash, crusting. So there may be a change in the nipple. It may be inverted, go inside. You know, the nipple is usually supposed to come out, so it may start entering inside. That's an indication that something abnormal is going on, is pulling it in. Sometimes it may look, the area around the nipple may look inflammatory red, or there may be rash or some peeling, or that's the crusting. So these are signs and symptoms that will make you want to visit your physician to help you look at your breast and tell you that you're fine. So skin changes in the breast too, these are also things to look at. Sometimes it looks like a dimple, sometimes it looks like the peel of an orange. So it may look like the peel of an orange. It may also look bigger than the other breast. So that is breast asymmetry. So we advise that every woman should have a familiarity with their breast and know what their breast actually feels or looks like, so that when something abnormal is there, you can actually point it out on time and know that something is wrong. So these are just pictures of some of the things I have described. Sometimes the lump can be in the armpits. It may not even be in the breast. It may be in the armpit. So if you see a lump or a swelling in the armpit, you should let your doctor know. And the skin color too may change. It may become red, it may become darker. So these are signs that will make you want to see or consult a doctor. This is just a brief guide as to how to do a breast self-examination. So when I just said you should have a feel of what your breast feels like. So if it's something you've been doing over the years, when an abnormal thing comes there, you would know on time. And so this is just a brief explanation of what a breast self-examination on how to examine yourself looks like. So some people prefer to do it lying down. Some people want to stand in front of the mirror while they do it. So you first want to look at it and see if there's any asymmetry. Look at your breasts as you stand in front of the mirror. You can put your arms on your hips so that you can have a firm grip on your hip, and it will make the breast tend to be tensed and to come out well. And so you can see the size, you can see the shape, and if there's any dimpling or swelling, it will be obvious. And while lying down, you want to look at 4 quadrants of the breast. You divide it into 4, or you might want to go in a clockwise motion, and using the palm of the right for the left breast and using the palm of the left for the right breast. So you want to palpate all around, look at all the quadrants and feel round it using the palms of your 3 middle fingers, or 4 of them. And then you also not forget to do the armpit as well. With your arms raised up, you also check for the armpit. And then you do the same to the other breast. And after you've done this, don't forget to also apply pressure on the breast to see if there will be any nipple discharge. So you squeeze with your thumb and index finger to see if there's any discharge from the breast. So we have a lot of screening modalities, starting from the self-breast examination, which I have just explained. Then the clinical breast examination, you need a qualified medical personnel, not just any roadside person, to help you examine your breast at least once a year, because sometimes you may not really know what you're actually looking for. So somebody who is qualified and trained to do it will be able to do a better job than you. And then mammography is done. Mammography is indicated for individuals who are above the age of 40 years, as recommended by the American Cancer Society. Some places will say women above the age of 50 years, because at the age of 40, for some women, their breast is still dense. So the mammogram may not actually pick any lesion, and there may be something there. So a breast ultrasound is also useful. It can be used in women who are less than 40, from age of 20 and above, can do a breast ultrasound yearly or every 2 years, depending on the risk of that individual. For individuals who have family risk factors, maybe their sister or their mother, then they have to do mammography and breast ultrasound more often than others, than the general population. So breast ultrasound is also useful. Some women also complain that mammography is painful. So for those women who find it as a painful experience, instead of not having anything done at all, I advise they do breast ultrasound with a diagnostic center that has a high resonance frequency probe that can do a breast ultrasound. So not every probe is good for doing a breast scan. So you need some special probes to actually get what you're looking for. So when a lump is discovered, what do you do? So I've had people who've discovered the lump, and then they get to their physician, and then the next thing that is done is that the doctor removes the breast, or removes the lump. Removes the lump, not the breast. And so this is not advisable. Don't let anybody remove your lump. Before a lump is removed, we must do what we call a fine needle aspiration cytology. So this is just a small needle, just about the size of the needle we give for intramuscular injections, and it is put into the lump in the breast, and we try to aspirate what is in the lump and put it on slides, and we look at it under a microscope to see whether it is malignant or not. So if we do that and the result comes out and says suspicious or malignant, then we know the person has to be treated. If it says suspicious, that is not so sure, then we might need to do what we call a true cut biopsy. Or for patients who say, if finding through aspiration says malignant, we will still do a true cut biopsy for those ones as well. So true cut biopsy is actually done, is a bigger needle, and it's done to take a bigger sample of the tissue in the lump, so as to look at it under the slides or microscope and see if there are cancer cells there. So you actually want to see that is there any cancer cells in this lump. So a true cut biopsy is a bigger and gives a more confirmatory result than a fine needle aspiratory cytology that says C3, that's suspicious for malignancy. So when the biopsy is done, so the true cut biopsy is done, it gives us some findings. One of those findings is to tell us if it's an in situ carcinoma or an invasive carcinoma. So if it is an in situ carcinoma, that's ductal carcinoma in situ or lobular carcinoma in situ, it just simply means that the tumor is confined, it's not yet invasive, and the risk of having it in the bloodstream or in any vital organ in the body is low. And so such patients, when they discover that, they need to have treatment on time so that it does not become invasive. And if it is invasive, those individuals will also have to have treatment. So when the histology is done, that's the part 1 result. So there's a part 2 result that follow-ups. That is a follow-up of the histology, the first histology result. And this is called immunohistochemistry. The immunohistochemistry is a test that your doctor should ask for. If you haven't done one, as a breast cancer patient, you must have one done. One, you look at the estrogen receptors. You look at the estrogen receptors are looked at, the progesterone receptors are looked at, and the HER2 new overexpression is looked at. So the immunohistochemistry result is actually a way we try to ask that breast cancer in that breast. We want to ask some questions. What particular drugs would you respond to? What kind of behavior are you going to exhibit? And it gives your doctor a sense of direction in how to treat you. So if your doctor is treating you without the immunohistochemistry results, that is not in your favor. The immunohistochemistry result plays a vital role in your treatment. However, sometimes in this environment, your doctor may actually start your treatment while waiting for the immunohistochemistry result. The reason is simply because sometimes the immunohistochemistry result doesn't come out as soon as you want, and we don't want a delay. We don't want the cancer to spread. And so because of that, we may say, okay, if we give the first cycle of chemotherapy, before the next cycle of chemotherapy, 3 weeks, your immunohistochemistry result will be out, and whatever modifications, additions, subtractions that needs to be done to your treatment can be done. So sometimes your doctor may start your treatment without the immunohistochemistry result, but your treatment should not be completed or cannot be completed without having an idea of what your immunohistochemistry is. So I've said we use the result to ask the breast a question: what kind of drug or what kind of treatment is best for this breast? And so the language the breast can speak can be to say that the 3 factors are triple negative, or the 3 of them are positive, we call that triple positive, or it says the estrogen is positive and the progesterone is negative, or the progesterone is positive, the estrogen is negative, or the HER2, the hormone receptors, the first 2, estrogen and progesterone, are positive, while the HER2 new overexpression is negative. So it can speak different languages and they mean different things, and we manage them differently. So these are the different treatment options we have for breast cancer. Ranges from chemotherapy, endocrine therapy, supportive therapy, targeted therapy, surgery, radiation therapy. So there's no particular order in which this treatment follows. Your doctor makes the best choice based on the stage at which you present. If it's an early stage, you may not need to do chemotherapy first. You may need to do surgery first and then chemotherapy follows. If it's maybe a stage 3, you may need to do some chemotherapy to make the tumor shrink before doing surgery and other treatment. So we do different treatments at different times based on so many reasons: the stage of the disease, the immunohistochemistry. For some patients who are strongly positive, the estrogen and progesterone are strongly positive, sometimes we just give them endocrine therapy, and then that alone can work like chemotherapy and shrink their tumors. So different ways in which your doctor will choose and decide how your treatment will go. So this is just to say that we have disease factors to look at: the biology of the tumors and how they are expressed. And so many advances in management and treatment have led to longer survival. So we have so many treatments coming out every day that has made patients live longer and have better quality of life based on this information that is very vital to your doctor. For patients who need hormonal therapy, these are the endocrine therapies. For patients who are estrogen or progesterone receptor positive, and the positivity too differs. Some people are, because it's scored over 8. Some people are very positive. They can score 8 over 8, 7 over 8. Some people are weakly positive. They can be 2 over 8 or 3 over 8. So all this just means that the way the person will respond to hormonal therapy will also be different. So people who are premenopausal, who have not attained menopause, what we give them is a bit different from what we give women who are postmenopausal. And sometimes for premenopausal women, you may want to start them on their own kind of drugs. Then after 2 years, the drugs can actually make them go earlier into menopause. And so for people who are on tamoxifen, you may have them complaining of hot flushes, irritability, symptoms that menopausal women will present with. And so when that happens, that may be an indication for your doctor to actually switch your treatment to that of the postmenopausal women. So we can switch the drugs and we can use different ones. And so the LH-RH agonist goserelin is also effective in premenopausal women. And sometimes we can do ovarian suppression or ovarian ablation. That simply means that we take off the ovaries of the woman. So we can remove the ovaries, or we can use radiotherapy to suppress the ovaries so that we reduce the production of estrogen for that individual, since the breast is speaking a language that says, I like estrogen. And so if the breast is saying that, we want to deprive that body of estrogens. And so for the postmenopausal women, some of them will actually also respond to tamoxifen. A few percentage, about 30% of them will respond to use of tamoxifen. So tamoxifen can also be used for some of them. Chemotherapy agents, there are several of them. There are single agents, there are combined agents. So your doctor chooses what is best for you and decides how many cycles you'll be received. So most often times, the minimum number of cycles of chemotherapy we give is 6 cycles. Sometimes we can do 8. Sometimes we give and the person does not respond and we switch to another line. And so, but majority of times, between 6 and 8 cycles is what you are going to take. Targeted therapy, these are special drugs that we give based on what your immunohistochemistry says. So for an individual, so because we're saying target, we're targeting something specific now. So for an individual who is HER2 positive, overexpression of HER2, so we put them on some special drugs called trastuzumab, pertuzumab, and we add it to their chemotherapy. So what it just simply means that patients who are HER2, who overexpress HER2, and you add these special drugs to their treatment, they have a significant improvement and an overall survival and a reduction in death rate for them. So if they are able to take that drug. So women who are HER2, who overexpress HER2 can benefit from that. Other indications, other recommendations are use of lapatinib with chemotherapy. Lapatinib is also a targeted therapy. We also have everolimus, we have Kadcyla, we have quite a number of them. And these ones I've mentioned are some of the ones that already we have available in Nigeria. The only challenge with most of this targeted therapy is their cost. They are expensive. And that's because of the role they play in management of cancer patients. So for these patients who overexpress HER2, they can benefit from it. For patients who also express, who are triple negative, they also have their own form of targeted therapy that they can also receive, which will be of benefit to them. So surgery can be wide local excision. Wide local excision is done for women who have a small tumor, which is not too big. And so that tumor can be easily removed without disfiguring the breast or without tampering with the nipple. So sometimes when we use chemotherapy and the tumor becomes smaller, we can do a wide local excision. So what I'm saying in essence is that it is not every time a woman has breast cancer that the breast must be removed. So sometimes we can just do a wide local excision and the breast still stays. Then some people can also have what we call a breast conserving surgery, which is just a modified form of wide local excision, and implants or flaps from another skin from another area in the body can be used to make up for the breast tissue that was removed. So there are different modified surgeries that we can do. So, but for women who have a big lesion in the breast and have the breast distorted in such a way that surgery is not possible, while local excision is not possible, they may need to do what we call a mastectomy, which is the total removal of the breast with removal of some of the nodes in the armpit. So your doctor would advise you on what is best, or your views, your opinions, and your decisions will always be respected by your doctor to give you the best that you need. Radiotherapy is use of cancer machine. Cancer machine is a machine that we use for local treatment. So it treats the area around the breast where the surgery is done. And so we do what we call, it could be radical treatments and it could be for palliation purpose. So radical treatment means that we want to aim at achieving cure or some level of cure for that individual. We don't want the cancer to come back. So we're a bit more aggressive with the radiotherapy. Radiotherapy has minimal side effects compared to chemotherapy. The most worrisome one, I think, is just the skin reactions. The feeling of nausea, vomiting with chemotherapy doesn't come to play with radiotherapy. So radiotherapy is a bit more friendly treatment. And so radical treatment goes for about 18 to 25 days, depending on what your doctor wants to, how your doctor wants to have you treated. Palliation with radiotherapy is when the person has pain or is bleeding, or the person has spread to the spinal bones, and we don't want the person to become paraplegic because we want to salvage the bone, or to control the local disease. Probably surgery can no longer be an option and you don't want the disease to continue to spread. You want to give a local control. So radiotherapy can be used for these individuals. And radiotherapy treatment is available in Louth. The machines are very big machines that they are not machines you find just anywhere. They are found in only special places and specific places in the country. And Louth has the radiotherapy machines. Louth has 3 machines and the services are available. So there are lots of supportive therapy for breast cancer patients. This is just one of them that I'm mentioning because patients who have bone metastases will most oftentimes need to be treated with bisphosphonates. These are special drugs that help to make the bones stronger. Some individuals who are also on chemotherapy or on hormonal therapy, and who their doctor feels that because of their age and they're at risk of having osteoporosis, the doctor may want to put them on bisphosphonates to help to strengthen their bones, or put them on oral calcium or vitamin D for a while to help them to strengthen their bones. Patients who have bone metastases can also have bisphosphonates, and in addition, will have radiotherapy and may require surgical stabilization to their spine so that they don't have cord collapse or become paralyzed. So these are some of my references for the presentation, and this is my parting word to my patients there, that no matter how bleak the horizon is, there will be light at the end. You must keep hope alive because you will surely get through this. Thank you for listening. This is my last slide. Thank you all.
Thank you so much, Dr. Alabi, for that lecture.
You're welcome.
We appreciate you for all that you do. We'll go to the next agenda on our program. So please kindly join me to welcome Mrs. Adeoye Fadekemi. She's the laboratory manager for the... Ms. Adeoye, please, over to you, ma'am.
Good afternoon, everyone. Good afternoon, everyone. Hello.
Good afternoon. Good afternoon.
Okay.
Good afternoon.
I am Adeoye Fadekemi. So I will be sharing some little experiences we have in the specialist laboratories with us, most especially on our immunohistochemistry. So it's going to be immunohistochemistry processing as it is being done in the specialist laboratories. Immunohistochemistry, as we have been told, is a type of staining used to identify cancer cells. And it is very important in determining the treatment, as our consultant have highly said. and it helps in classification of cancer and locating the primary source of metastatic cancer lesion. Immunohistochemistry help in better diagnosis, as we have said. So here we would like to tell all our physicians, the hospitals, patients and relations that are online, that these are the expectations we at the specialist laboratories want from them. Number one, we want all the samples to be fixed immediately it is removed from the body. Why is this done? It's done so that it will prevent the sample from degenerating, from decaying, because the life is no more in that sample. So to prevent these processes from occurring, we prefer the use of 10% neutral buffer formalin, which is very good in treatment. And also, proper filing of clinical details. Age, sex are very important. Everything that needed to be known about the patient, whether the person is on chemotherapy before the sample was taken, or what are the histories that needed to be known. So these are what is expected from our clinicians, physicians, patients, and individual that is coming. Patient relations should be encouraged to deliver specimen within the space of 12 hours after surgery. As I've said earlier on, that sample immediately it is being removed from the body, it tends to degrade, to lose its value. So autolysis sets in. That means that degradation is now decaying because there's no more life. So it's expected to be delivered with the fixative into our facility within the space of 12 hours maximally, so that there won't be autolysis. And autolyzed samples, they are not suitable for immunohistochemistry. Overfixed samples are not suitable for immunohistochemistry. Peradventure, the sample is left for a very long time in fixative, it will not give a good outcome for immunohistochemistry. Peradventure, patient is coming, he has done his sample somewhere outside and wanted to do second opinion or immunohistochemistry with us in the specialist laboratories. We expect the sample to come with corresponding hematoxylin and eosin slide, and which is same cases for second opinion, which we send abroad. In specialist laboratories, we have qualified personnel handling all our specimen, and reproducible of our results is our ultimate goal, which we'll really take into consideration. And our turnaround time for each of these results to be released is maximally 7 working days. In most cases, at times it tends to reduce beyond that day, but 7 working days is the maximum number of days our results is being released. We have archiving procedure in our laboratory. We can keep our blood samples for as many years as possible for future references and further investigation as necessary. This is a short adventure to our immunohistochemistry laboratory. In our immunohistochemistry laboratory, we are automated, and we have the capacity, the automatic machine has the capacity of running a minimum of 24 slides, 24 slides per cycle, and within the space of 3 hours, or depending on the number of samples, but per day we can run as long as 48 samples from individual patients. So that means with estrogen receptor progesterone receptor meant for staining while in our patient's recovery. And
Thank you so much, Mrs. Adoye, for that brilliant presentation. We appreciate you for all that you do. Please, do we have any questions? Does anyone have any question? Okay, there's a question here and it says, I would like to know the recommended follow-up for patients on tamoxifen as it is associated with a risk of endometrial cancer. I think that question is for Dr. Alabi. Hello, can we hear me? Hello?
Yes, we can hear you.
Okay, I'm so sorry. I couldn't hear myself.
Yes.
So that question is for Dr. Alabi. Please, ma'am, can you please kindly help us do justice to that? Thank you.
Okay, so the risk of endometrial cancer, yes, it's possible for patients on tamoxifen. So what we usually do is that patients who have breast cancer, we try to, there's a follow-up pattern they have. So part of their investigations includes doing an abdominopelvic ultrasound. So when they do an abdominopelvic ultrasound, if there's anything in the endometrium, we will see. And apart from that, we are very, very mindful of the fact that if there's any complaint that is related to them having, if there's any complaint about them having vaginal bleeding, abnormal vaginal bleeding, abnormal vaginal abnormal low abdominal pain, we are also very weary in requesting for an abdominal ultrasound or CT scan if need be. So we don't routinely say we are looking for it, but we have it at the back of our mind that that is a possibility. And when they do ultrasound, we look at the endometrium. So I don't know if I've been able to answer that question.
Okay. Please, has Dr. Alabi been able to answer your question? Okay. I want to believe you got the answer to your question, Prof. Okay. So there's another question here, and it says, you mentioned that patients are treated with Herceptin, which is a very expensive drug. What is being done to make it affordable?
So in Nigeria, part of the things that we do to make it affordable includes ensuring that patients are registered with NHIS. So there's a package for people who have NHIS, not for everybody. So I don't know the criteria that NHIS uses. So, but I'm aware of some patients who were lucky to have gotten their Herceptin through NHIS. So we also encourage, not just Herceptin, some chemotherapy drugs are available through the NHIS. So try and register for NHIS. So apart from that, we speak with the companies from time to time. When Herceptin initially came into the country, Herceptin was at a cost of about 650,000. And so now Herceptin is about 320,000 per cycle. So you would this is just to say that there is work in progress about the cost of targeted therapies generally. So, and some NGOs also sponsor patients for Herceptin. I'm aware of a few NGOs that have sponsored patients for Herceptin. I'm also aware of some churches and some NGOs who have also sponsored patients on Herceptin. So these are some of the things that have been done regarding how people get or how they assess the Herceptin.
Okay, there's another question here for you, Dr. Alabi. It says, is it true that breast lump that is not big and biopsy confirmed it's benign? Do you want me to take that again, Dr. Alabi? There's another question for you.
Please.
Okay, it says that, is it true that breast lump that is not big and biopsy confirmed, it is benign and should not be removed?
Okay, so for that, especially for individuals who are above the age of 25, so if they have a breast lump and biopsy confirms that it is not malignant, that it is benign, that's what you're saying, it should actually be removed, because we have seen some cases where probably the imaging, like the ultrasound or the mammogram, didn't say it is malignant, and then it is removed, and then the result comes out to be malignant. So some cases have actually been proven to be like that. And so because of that, we advise that every lump should be removed. So the only difference between the removal of the lumps is if it is malignant, we already know it's malignant. The way to be removed is completely different from the way a benign lump will be removed. So a malignant lump is removed with the mindset that the patient can have it spread or can have the tumor come back, and we don't want that to happen. And so because of that, we would insist on having it removed in a special way. But if it is benign, then it can be removed by any surgeon.
Okay, Dr. Abi, there's so many questions for you, but we'll just take a few because our time is far spent. So we'll take like 3 more questions, and that will be it for questions. So there's another question that says, is automatic, is it auto, I guess the person was going to say that, is it automatic for a person to have cancer based on the family history? I guess Dr. Labi already answered that while
Yeah.
she was
So let me
teaching.
just say something with regards to that. So if you are worried that it's automatic, so what can actually be done for that individual is to do a genetic screening. Genetic screening is now available. I'm aware that some laboratories run it. And so if a genetic screening is done, you can actually identify if the person has BRCA1 gene or BRCA2 gene, which may make that individual susceptible to a malignant lesion later. So that can be done. So genetic screening is what that individual needs. So it's not really automatic like that, but if a genetic screening is done, it tells you that you have like 60% chance of also having a malignancy. So that's what it does.
Okay, Dr. Abi, there's another question that says, can we say that cancer is incurable?
Okay, no, so we can't say cancer is incurable. So we would rather say cancer is curable if detected early. If the person presents early, it is curable, yes.
Okay, so the next question is, can the removal of the affected breast put an end to the cancer?
So that comes to be because when we talk about staging, and so removal of the breast alone cannot put an end to the cancer because we don't even know if before the breast was removed, if the cancer had spread. So the whole essence of giving chemotherapy is because we're thinking that these patients may have the cancer spread. And so when we give chemotherapy, we expect that the chemotherapy will circulate through the body, go around the body to areas where the cancer is actually hiding and deal with the cancer there. So it can actually spread. So removal of the breast alone may not suffice for taking care of the cancer.
Okay, this is the last question for Dr. Alabi. The last question says, what relationship is there between brow wearing and breast cancer?
Well, from the risk factors I have mentioned, I didn't put brow wearing there. So there's no relationship that I'm aware of. So there's no relationship that I'm aware of.
Okay. For now, we don't have any question for Mrs. Adeoye. And I think that would be all for today. I'd like to appreciate our guest speakers and appreciate every attendee for being a part of this meeting. We know that what we discussed today is a very important topic, and it may not be for you, but it may be for someone in your community. It could be members of your church, it could be members of your family, it could be members of your immediate community. So thank you so much once again for this time, everyone. Thank you for attending. If you have further questions, the number to call is 0812-84923. And you can Google us and get more information about us on the internet. And then you can also send us a message via email or via the phone numbers displayed on our website. Thank you again, everyone, for coming. I appreciate you, Dr. Labi. You're so amazing. Thank you. Love you.
Thank you.
Thank you, everyone.
Fún mi ní kíkan nù kí yẹn. Ṣé kíákíá jọ? Kó má bàa pọ̀ síbẹ̀. Ó fẹ́ máa gbọ́n. Mo fẹ́ gbé ṣé kékeré yẹn sìn.